Good morning, everybody, and thank you very much indeed for inviting me. Gordon, Helen, and all the Lymphoma Action team. And I must say, I really love the new title. I think it's much more snappy and modern and descriptive than Lymphoma Association. So I think I wish you all good fortune in the future. So this is what I've been asked to talk about, clinical studies and trials. And I suppose the question arises, why do we want to do any of this anyway? Why can't we look in the book and find out which treatments we should apply in certain circumstances? And I think the answer to that is that certainly professionals in the field are really interested in understanding lymphoma better so that we can start to, as it were, relate that understanding to the patients that we see. And we also want to develop new and better treatments because the existing treatments may not be as good as we would like. And although there's no doubt been huge progress over the last few years in terms of improving outcomes for people with lymphoma, and that's a really positive message, there's still work to be done, and we need to focus on developing these new therapies in the best possible way. And there's two aspects for that. One is inventing new treatments, so new molecules, and Adam Gibb this afternoon is going to be talking about the new treatments that are becoming available. But there's also using the existing treatments that we have better. Can we be smarter about using these treatments in a less toxic way? Can we use less treatment in certain circumstances and only focusing more intensive therapies on those people who really need them? And I hope to be able to show examples of that in the next few minutes. But we're also interested in how do we do certain things? What about follow-up? How do we follow people up in an effective and helpful way? Are the ways that we're following people up currently useful, or could we do it differently and more effectively? And what about late toxicity? How can we actually manage late toxicity in a way that mitigates the effect of it so that people can live full and healthy lives if they've been cured of lymphoma, or if they haven't, living with cancer for many years successfully. So that's the theme of my talk, and I'm very happy to take some questions at the end. So I'm going to concentrate, although lymphoma is a huge subject, and as Kathy's just shown, there are many different subtypes of lymphoma. I'm going to show general principles and apply this essentially in the field of Hodgkin lymphoma because I think this just gives some useful illustrations. So the first slide I'm going to show, if I can get it to work. Now, what's going on here? It is up there. So this is a slide about a trial that was done, led by Peter Johnson here in the UK, in Southampton. It was an international trial. It recruited very quickly. It was the largest trial that the UK have ever done in Hodgkin lymphoma, the so-called Radford trial. The results were published by Peter and the team in the New England Journal of Medicine in 2016. And what it was looking at was the treatment of patients with classical Hodgkin lymphoma. So you remember Kathy showed you some slides of CHL in her talk. So patients with classical Hodgkin lymphoma, advanced stage, how do we treat it most effectively? And can we integrate some of the new imaging techniques that are now available? And PET scanning is the one that I'm talking about specifically. Can we use PET to determine how we should give treatment better? So up to that point, standard treatment had often been with either ABVD or BRCOP chemotherapy, 6 cycles, and that was the end of it. What we're asking here is, could we use PET early on to, as it were, reduce the amount of treatment for some and intensify the amount of treatment for others? And so in the Radford trial, everybody got 2 cycles of ABVD, and then they had a PET scan. So they've already had a PET scan at the beginning to stage the disease, but then they have a PET scan early on, not at the end, but after 2 cycles of chemotherapy. And the point was that if the PET scan was positive, indicating residual disease, then those individuals would have escalation of treatment to BIACOP. They'd have a third PET scan. If the PET scan was by then negative, they would complete BIACOP and be followed up. If it was positive, then they'd have some other salvage treatment. So that's the PET positive arm. The PET negative arm, in other words, we're saying that this is for people where the disease we think has been eliminated. Those individuals were randomized, so randomly allocated between continuing ABVD or dropping off the B, the bleomycin, and giving AVD alone. And those individuals would also be followed up. So in other words, what you can see is that treatment is being governed or managed by the result of the PET scan after 2 cycles. And what it showed very clearly was that in terms of the PET negative patients, as you can see on the left, this is the proportion of people alive and disease-free. And there's the 2 lines which indicate the 2 different populations of patients lie above one another. In other words, the results are identical. And what that showed very clearly, therefore, is that if you've got a negative PET scan after 2 cycles of ABVD in classical Hodgkin lymphoma, it's possible to drop off a drug, reduce the toxicity, and continue with a less toxic alternative. So that's a really important observation. What I want to just do now is flip slightly to talk about a new agent called brentuximab vedotin. So brentuximab vedotin is a so-called antibody-drug conjugate. So it's an antibody linked to a small molecule, and what happens is that the antibody is able to recognize a certain target, CD30, which is on the cell surface of certain lymphoma cells. And the antibody-drug conjugate targets to that area, the CD30. The complex is internalized. A very clever chemical linker breaks. The small molecule is released, and it's able to do its damage. And here it is. There's the brown blobs of the small drug molecule. The blue lines is the so-called anti-CD30 monoclonal antibody. And what happens is that it's attracted to the CD30 target. It goes into the cell. The blue blobs, the drug, break off. And the drug, which is called monomethyl aureomycin E, MMAE, is able to do its damage and kill the cell. So this is a really important new development. It's the first drug that has really been developed in lymphoma, or certainly in Hodgkin lymphoma, for 2 or 3 decades. So that's a really important step forward. And so what we've done is make use of this in a subsequent clinical trial. So if you remember, I talked about the Radford trial looking at the use of PET scanning. What we've done here is take the information from Radford, using PET as a way of determining what we do, and adding brentuximab vedotin to chemotherapy to see if that improves the outcome. So in this particular study, Echelon 1, this was a worldwide study. Patients who consented to take part were randomly allocated between standard ABVD and AVD plus brentuximab vedotin, with the same use of PET scanning as was used in the Radford trial. And what we showed from that, and these results were published in the New England Journal of Medicine in 2017 and were presented at the ASH meeting in December of last year, is that there's a significant advantage for the combination over the chemotherapy alone. And as a result of those data, in the US at least, this treatment has been licensed for use in advanced Hodgkin lymphoma in combination with chemotherapy. So the blue line there are patients who received the new combination. The red line is people who received chemotherapy alone. So as you can see, we've moved from Radford, making use of PET scanning. We've done some work identifying that brentuximab vedotin is a really important agent in Hodgkin lymphoma, and we're now integrating chemotherapy with this new agent and finding that that combination is better than chemotherapy alone in advanced Hodgkin lymphoma. So that's what we like to try and do. It doesn't always work out, but what we like to try and do is build on the results of one study to develop the next so we can try and push the subject forward. So that takes us back to another trial that we did, again in the UK. This is the RAPID trial that I led and was published in the New England Journal of Medicine in 2015. And this is an early stage Hodgkin lymphoma. Radford and echelon 1 were advanced stage. This is an early stage disease. And once again, we made use of the PET scan. And what we did was, if the PET scan was positive after 3 cycles of chemotherapy, then that suggested that there was still disease present, and those individuals had further chemotherapy and radiation treatment. On the other hand, if the PET scan was negative, suggesting that the disease had been eliminated, those individuals were randomly allocated between no further treatment and radiotherapy. And what we found is that there was a small difference in outcomes between the two groups. Those people that had radiotherapy in addition to chemotherapy did slightly better than those who had chemotherapy alone, but the difference is not that great. And for the majority of people who've had chemotherapy alone, not only have they been spared the late toxicity of radiotherapy, but they haven't had to receive that treatment in the first place. So this was a very important observation. It showed that not everybody with early stage Hodgkin lymphoma requires chemo plus radiation treatment. So the question is, how do we improve those results? And we try and do that by integrating this information with some of the science that Kathy Burton was displaying earlier. So if you remember, she talked about gene expression signatures and making use of the molecular makeup of the tumor to be able to better understand how it's going to behave. And that image in the top left here shows, for the same diagnosis, a very different outcome according to the gene expression profiles of the tumors concerned. In other words, 100 people with Hodgkin lymphoma, half of them might have a particular gene expression profile, half might have a different one, and the outcomes, although they've got the same disease, is very different. So in other words, the molecular makeup of the tumor is very critical in determining what happens. And so here we go back to Kathy's images of the tissue biopsy. There's the cassette. The RNA is extracted. The various molecular tests are done. And what we come up with is a heat map, which, as you can see here, there's a lot of green on that side, there's a lot of red on that side. That's the difference between the two. And what we can tell is that those who have a lot of red, in other words, certain genes that are being expressed, do rather worse than if those genes aren't expressed. And so it's a very clear demonstration of how gene expression makes a difference in terms of what is going to happen to those patients. And so how can we make use of this in terms of the future? And I think the key thing about it is that we want to, in terms of the RAPID trial, so what we'd really like to do is improve the discrimination between patients requiring radiotherapy and those who don't. In other words, how can we better decide at the beginning? We can't do it just by looking at the patient. We can make a good guess from the PET scan, but if we could improve on that, so much the better. So that's one objective. The second objective is that we want to increase the PET negative rate from 75% to a higher level, because we know that if we can do that, that suggests that the outcome will be better. And we'd like to improve the outcome from those people who acquire PET negative status. And we'd also like to eliminate bleomycin, which is a very well-known lung toxin. And so what we're doing is develop another study called RADAR. And so the RADAR study is going to be across the world, so Australia, New Zealand, US, Canada, UK, certain countries in mainland Europe, Scandinavia. And we're going to be taking the basics of the rapid study that we did and comparing chemotherapy with chemotherapy plus brentuximab vedotin, so rather like the Echelon-1 study, but in early stage disease, and making use of the PET scan to be able to tell us whether we should continue with more treatment or stop or give radiotherapy or not. And so, once again, I hope you're able to see that we're really trying to make use of this information to, as it were, improve the way in which we give treatment. What about the slightly older person with Hodgkin lymphoma? So we know that in the main, most people with Hodgkin lymphoma are of a younger age group, so the average age at which people present with the disease is 29, 30. But there's also a group of people who are older, in the late 60s, 70s. And what we also know, and this is where clinical studies really become extremely valuable, we know by observing outcomes that the outcomes in patients who are slightly older is substantially less favorable than it is for the younger people. Why is that? One reason is because the Hodgkin lymphoma may be biologically different. The other is that patients who are older may not be able to tolerate the treatments as well, and they might have to have smaller doses or delays in between treatments. And they might also have other problems, such as heart disease or diabetes or other medical conditions. And so what we've been doing is trying to establish a different way of treating people other than with chemotherapy. So once again, brentuximab vedotin, we did a so-called phase 2 study where we took a relatively small number of patients. We offered this treatment to those individuals, and if they agreed that this is what they wanted to do, we treated them with brentuximab vedotin rather than with chemotherapy. And what we found is that there was a very high response rate, but the response did not last as long as we would hope. And for those individuals, additional treatment was required. So what we've done, and what we're trying to do, is learn from that experience, and we've created a further study called Abacus, and that is going to be a combination of brentuximab vedotin and avelumab. So I don't know if you've heard of avelumab. It's one of the so-called checkpoint inhibitor drugs. Nivolumab has recently been approved by NICE for use in Hodgkin lymphoma patients where the disease has come back after transplantation. Avelumab is the same sort of drug. And these checkpoint inhibitors essentially work, and this is a sort of cartoon idealization of what it might do, by releasing the handbrake on the immune system. So if you imagine the immune system as a vehicle and it's parked on a hill, you take off the handbrake and it starts to roll. And that's exactly what checkpoint inhibitors do. They release the handbrake and allow the immune mechanisms that naturally are there to act more effectively against the tumor. And so what we're doing is combining brentuximab vedotin, which we know has a very high response rate, with avelumab, which we know helps the immune system to work effectively in patients with Hodgkin lymphoma. And we're comparing that with some really rather old-fashioned chemotherapies that are still used, which are well tolerated. What we want to find out is whether this new combination is better. So that study is going to be opening, we hope, next year, and we're working in collaboration with colleagues in Birmingham in terms of the clinical trials unit there, but also across the whole of the UK through the so-called TAP network, which is the Trial Acceleration Program Network. So I think I'm running out of time, Jade, is that right? So I'm just going to give a couple more examples about areas where we're quite interested. So I mentioned about we're trying to devise new therapies, we're trying to integrate new molecules into the mix, we're trying to use old treatments better, more cleverly, more smartly. But we're also interested in how we do things. You know, how do we actually follow patients up once they've completed treatment? So recently we did a survey of patients with Hodgkin lymphoma. And the question was, how long do you continue follow-up after treatment for Hodgkin lymphoma? This wasn't the patients, this was the physicians looking after the patients. There were 27 responses. The average duration of follow-up was 5 years, which had a spread of 3 months right up to indefinitely. So a huge difference in practice across the country. 15 responders said 5 years, 8 responders said less than 5 years, 4 responders said 10 years plus. So as you can see, for something really simple like follow-up, within the UK, which is a relatively small country, there's a whole range of doing the same thing differently. There is one individual who's following patients up for 3 months after completing treatment, and there are others who never discharge them. So what's right? I don't know what's right, and what we need to do is find out. And so that produces the appetite for a study in this field, and so that is what we're currently engaged with. And we've got a study called Transform, which is designed to find out exactly how to do this better so that we understand what the issues are. And if we can find out what the answer is, we can then, as it were, write a guideline that will allow everybody in the country to be followed up in the same way so that there won't be this spread of practice that currently occurs. And so what we're going to be doing here is comparing hospital follow-up with or telephone follow-up after 1 year. So everybody will get hospital follow-up for 1 year, and then following that time, people will be randomized between continuation of that or or telephone follow-up. And we'll be looking at patient responses, anxiety, depression, quality of life, and we hope that that will tell us a lot about how we should follow up people in the future. And what we're also going to be doing is taking blood tests during those hospital visits and seeing if we can identify Hodgkin lymphoma signature in the blood so that in the future what we'll be able to do is have a so-called biomarker-led surveillance program. So in fact, all it would require perhaps is for the patient to go to their GP, have a blood test, and then get a phone call to say, your blood test is fine, let's continue. You don't need to go to the hospital, or there might be a query and a scan might be required at that time. So in other words, and I think Jane is getting restless, so I better move on. I think what is really clear is that although there's been huge progress, there's no doubting that, and that's really to be welcomed and congratulated, there's still a huge amount to be done. There are lots of questions that need to be answered. There are lots of processes that we need to understand better. And for all the people who've taken part in trials, whether in Hodgkin lymphoma or other types of lymphoma, can I just say thank you very much, because without that involvement, we can't answer these questions. And can I encourage you to, as it were, support clinical trial activity across the UK by talking to others and encouraging them to get involved with this sort of work. So thank you very much indeed for listening. I'm very happy to take some questions. It's been great to be here. Thank you.